Hi guys, it's me, Professor D, and welcome back to my channel. On this video, I'm going to be covering all things integumentary. Well, not all things, guys. I only have 30 minutes, but I'll be covering a lot of skin issues, and I'm going to make sure I make a part 2 for you because there are a lot of concepts about skin that are very important for you to know. As always, guys, please be sure to like and subscribe below. Press that little bell button so that you get a notification on Thursdays when new videos are released. You'll be notified that there's a new video out. Without any further ado, let's get started. The nurse received morning shift report on the following clients. Which client should the nurse assist first? Which client should the nurse assess first? 1. The client with a right total knee replacement who wants to be removed from the continuous passive motion machine. 2. The client diagnosed with chronic low back pain who's crying and upset about being discharged home. 3. The client who is 1 week post-op for right total hip replacement who has a temperature of 100.4. Or 4. The client who has full thickness burns who needs to be medicated before being taken to Whirlpool. If you're new to my channel, just go ahead and press the pause button to give yourself enough time to think of your answers. And as soon as you formulated your answer, you can go ahead and press the play button to resume. So guys, the correct answer is 4. Now, if you've been following me for a while, you know that I teach this a lot. Pain never killed anyone. It never threatened anyone's physiological integrity except for 4 situations where you are going to treat pain as a priority. Any patient that's going through sickle cell crisis, that pain is a priority. Any patient that's had a myocardial infarction, you better give them morphine. You want to decrease the oxygen demand on the heart. Any patient that has stones, kidney stones, calcium stones, struvite stones, I don't care. If they're stones, pain is a priority. And the last one is burns. Any patient that has burn pain, you have to treat that pain as a priority because let me tell you, that pain is so intense, it will put their physiological integrity at risk. So guys, a patient that's going to a Whirlpool, let me tell you, that is one of the most painful experiences a patient can ever experience in their life. So that's a priority. You're going to make sure that that patient's medicated before they go to the Whirlpool. And I know what you're thinking. You're looking at 4 and you said, you know, Professor D, you said any patient that's had surgery, you always worry about infection. Absolutely. Absolutely. Any patient that's gone through surgery, you're going to worry about infection, DVT, pulmonary embolism, or hemorrhage. Yes, it's 100.4. You're going to go to that patient next. But that burn patient that's about to go get a Whirlpool, you absolutely must medicate them before they go to that Whirlpool, and you're going to go see that patient first, okay? Number 4 is the only one whose physiological integrity is at risk at the moment because 3 is 100.4, not 101. So yes, you're going to go see them next, but their physiological integrity is not at risk at the moment. Next question. The nurse is working on an ortho unit. Which client should the nurse assess first? 1. The client who's 2 weeks post-op open reduction external fixation of the right hip who's complaining of pain when ambulating. 2. The client who's 10 days post-op for a left TKR who's refusing to use continuous passive motion machine. 3. The client who's 1 week post-op for L3 to L4 laminectomy who's complaining of numbness and tingling of the feet. Or 4. The client who's being admitted to the rehab unit from the ortho unit after an MVA. And I'll give you a moment to think of your answer. And the correct answer is 3. The client who's 1 week post-op for L3 to L4 that's complaining of numbness and tingling. Come on. L3, L4, that's their spinal column. Okay, so if they're complaining of numbness and tingling, that's a sign and symptom of a neuro issue. Okay, that patient's physiological integrity is at risk. That's who you're going to go to first. Let's go over the other choices because I want to explain to you why the other ones are wrong. You have 1, the client who had an ORIF and they're complaining of pain. Remember, the 4 pains that are priority is sickle cell, MI, stones, or burns. And obviously this is not one of those. Guess what? They just had surgery. Yes, it's going to hurt when they try to ambulate. You know, we're going to try to medicate that pain, but it's not one of those pains that's priority. We're not running to that patient first. Choice 2, the patient who had surgery 10 days ago, and they're refusing to use a CPM machine. So the CPM machine is important. We don't want them to develop clots. We're going to have to talk to that patient, you know, find out what's going on, find out what the issue is, but their physiological integrity is not at risk at the moment. And then you have 4, the client who was just admitted from the ortho unit coming to your unit. Yes, you have to assess that patient, but if they're being transferred to you, they should be stable. So yes, you want to assess them, but that's not who you're going to be running to. Not when you had a patient that just had surgery on their spinal column and now they're complaining of neuro symptoms. That's who you're going to be running to. The nurse is preparing to administer the morning medications to the following clients. Which medication should the nurse administer first? 1, the NSAID to the client diagnosed with osteoarthritis. 2, the IV antibiotic to the client with cellulitis. 3, the antiviral agent to the client with herpes zoster, shingles. 4, the antihistamine to the client with urticaria and pruritus. And the correct answers for the antihistamine to the client with urticaria and pruritus. So let me explain this to you guys. Urticaria, that's when that patient has hives. That's what urticaria is, hives. Want to know what hives is? That is a systemic reaction. That is what you call a true IgE-mediated response. Not a little localized reaction. I'm talking about systemic, where that patient's throat can possibly just close up on them any minute and they can't breathe. So guess what? When a patient has urticaria, which is hives, you take that seriously, okay? Because you never know when their airway is going to be occluded or obstructed. Okay, that hives, that itching, that's a sign and symptom to let you know that that patient is having a true IgE-mediated response. They are having a systemic response, and you are going to be running to that patient. Why? Because that systemic response, it puts that patient's physiological integrity at risk. Okay, we don't get to that patient in time, they can die because, like I said, they could swell up all over and their airway can be occluded. Choice 1, 2, and 3, yes, you want to get to those patients, but none of their physiological integrity is being at risk. There's nothing that can kill them immediately, such as that patient that has now developed hives and itching. The client tells the nurse, I have a mole on my back, which is darker and getting larger. Which intervention should the nurse implement first? 1, tell the client to use corticosteroid cream on the area. 2, recommend the client use SPF 15 when in the sun. 3, instruct the client to notify the doctor immediately. 4, encourage the client to wear dark woven clothing when outside. And the correct answer is 3. You want them to get to their doctor immediately. So let's talk about this. And they gave us some hints. A mole that's getting darker, so it's changing in color, and larger, it's changing in size. Remember your A, B, C, D. A is for symmetry. You know, you have to suspect possible cancer if it's not the same on both sides. Your B, that's for border irregularity. When you look around the border of it, you know, if it's not uniform. C is color change. It just says in the question that it's getting darker. And D is for diameter. It just says in the question that it's getting larger. Right? So you're going to instruct them to go see their doctor immediately. I want to go over the other choices with you because this is how the test writers try to trick you. Because all of the other choices are great teaching that you're going to give the patient. These are wonderful teaching. However, to address the immediate issue, they need to go see their doctor. So And I lied, because one says tell the client to use corticosteroid cream on the area. That's incorrect. You can't play doctor. You don't tell them to put any medicine. The doctor is going to tell them what to do. So number one's completely wrong. That's not even a good choice. I take that back. Number one's completely wrong. Then you have number two, recommend the client use SPF 15 when in the sun. At least SPF 15, at least. But that's a good teaching. You want to teach them to wear sunscreen or sunblock. And then you have four, encourage them to wear dark woven color. I didn't read, did I? Because you see number four, you want them to wear light colors, colors that will refract away from the sun, okay? Not colors that will absorb the sun, but what you want to teach them is to protect their skin by wearing at least SPF 15. You want to teach them to, when they're going out into the sun, to wear light colors and not dark colors that will absorb the sun. You want to teach them to protect their skin, to wear long sleeves. You want to teach them to wear hats, to wear sunglasses, not to go to tanning booths, right? And all those other things that will protect their skin. But first and foremost, that issue about a mole that's getting darker, that's getting larger, you're going to teach them that they need to go see their doctor right away to get that investigated. The nurse is at a local playground and her 10-year-old son falls and complains of his left ankle and foot hurting. What intervention should the nurse implement first at the scene of the accident? 1, instruct her son not to move the leg. 2, elevate the leg on 2 rolled towels. 3, apply ice pack to the left ankle. Or 4, check her son's pedal pulses bilaterally. And the first thing you want to do, guys, is immobilize the area. Before you do anything else, you want to immobilize the area because you want to make sure that you don't cause further harm, further trauma to that area. Everything else you can do later. Your ICE. I is for put ice on the area to decrease the swelling. C is for the compression. E is for elevation. All of that you can do later. But the first thing you want to do is immobilize it. Immobilize it so you can actually look at the area and make sure a bone's not protruding, right? So you don't want to immediately move that leg and cause more harm and damage than good. So the first thing you always want to do is immobilize the area. The nurse is preparing to change a dressing on an 82-year-old client with a stage 3 pressure ulcer. Which intervention should the nurse implement first? 1, obtain the needed equipment to perform the procedure. 2, remove the old dressing with non-sterile gloves. 3, explain the procedure to the client in understandable terms. 4, check to determine whether the client has received pain medication. And I'll give you a moment to think of your answer. And the correct answer is 4. You're going to check to see if they received pain medication. And the reason for this, guys, is this patient has not a stage 1. Not even a stage 2, but they have a stage 3 ulcer, which means that this ulcer has gone down to the sub-Q fat area, right? So you changing that dressing is going to be painful. So you got to make sure that you provide analgesic to that patient before you change the dressing. Because guess what? If that patient has not been medicated, nothing else matters. Because we can't change that dressing until that patient's been adequately medicated. So I want to go over the other choices with you. Choice 1, getting the equipment needed. Choice 2, removing the old dressing. Choice 3, explaining the procedure. All of that happens after we know that the patient's been properly medicated, because then we know that we can go ahead and go through with the dressing change. So after 4, after you make sure that the patient has gotten their analgesic, the first thing you're going to do is get all your equipment, bring it into the room. Then the next thing you're going to do is explain the procedure in ways that that patient will understand what you're going to do. And then lastly, you're going to remove the old dressing with clean gloves and start the dressing change with sterile gloves. And just so you guys know, don't forget the difference between your stage 1, 2, 3, and 4. So with stage 1, the areas pink and non-blanchable. So you'll see a pink area, and you know how when you press down, it's supposed to blanch, and then the pink's supposed to come back. With your stage 1, it's just pink or reddened, I should say. It's pink or reddened, and it's non-blanchable. That's your stage 1. Once the integrity of that skin is broken and that skin is now open, it's a stage 2. Once it's gone down to the sub-Q area, subcutaneous level, it's a stage 3. Now, my goodness, once that thing has gone down to the muscle or the bone, you're at a stage 4. Guys, if you let a wound get to a stage 4, that's bad nursing. Okay? Because as a nurse, you should always be assessing your patient. Those patients who are at risk, such as your obese patients, right? They're putting a lot of pressure on that area. Your cachectic or malnourished patients, your patients that are really, really small or skinny. Why? Because they got bony prominences. Your malnourished patients, right? Your patients who, if they sweat a lot, there's a lot of moisture, okay? All of those patients who are high risk for pressure ulcers, your diabetics, the list can go on. Those patients who are high risk for pressure ulcers, you should be checking them more often. Right? So you should have caught that when it was a stage 1, much less a stage 2, 3, or 4. So it's very important. Make sure you guys know the difference in stages. Which client should the charge nurse on the rehab unit assess first after receiving morning report? 1, the client diagnosed with an ORIF of the right hip who has a hemoglobin and hematocrit of 8 and 24. 2, the client diagnosed with rheumatoid arthritis and has a positive rheumatoid factor. 3, the client diagnosed with stage 4 pressure ulcer with a WBC of 14. Or D, the client diagnosed with systemic allergies on prednisone dose pack who has a glucose level of 189. The correct answer is 1, guys. Yes, everyone needs to be addressed. But the patient you are running to, by far, it's not even a competition. The patient that you are running to is number 1. Remember what I told you. Whenever you get a question about a patient who's post-op, and I don't care what kind of surgery they had. I don't care if it was an ORIF. I don't care if it was a C-section. I don't care if they got the appendix removed. If they had surgery, you are concerned about infection, bleeding, and a DVT or a pulmonary embolism, right? Look at that H&H. 8 and 24. Now, mind you guys, the least number that the hemoglobin should be for female is 12. For male, 14. This is 8. Remember the importance of the hemoglobin. That shows how much oxygen, the capacity of oxygen in the blood, right? This patient is bleeding out. 8. So by far, guys, this is the patient that you're running to, okay? Because at 8, this patient most likely, they're going to need a blood transfusion. Look at our other choices. You have 2, a patient who has rheumatoid arthritis, and they're positive for for rheumatoid factor. Well, yeah, the rheumatoid factor is going to be positive. They have rheumatoid arthritis. There's no reason for us to be running to this patient. Yeah, we're going to go see them. Yes, we're going to go address them. But their physiological integrity is not at risk. Their life is not at risk at the moment. You have 3, the client with a stage 4 ulcer that has a WBC of 14. Now, you guys know your WBC, the normal range is 5 to 10. Anything more than 10, the patient has an infection most likely. Yes, but guess what? Once a patient has an ulcer, it went past the stage 1. It went past the stage 2. It went past the stage 3. That patient's at a stage 4. Most likely, yeah, they do have an infection. They're going to be on antibiotics. So yes, we have to see that patient, but their life is not in danger at the moment like that patient who's bleeding out is. Then you have the last choice, which is for the client who has systemic allergies. They're on prednisone. Prednisone is a corticosteroid. What do we know about corticosteroids? They can cause stomach ulcers. They're very hard on the stomach. They can cause fractures because they cause the bones to be porous. We worry about infections because they hide the signs and symptoms of infection. So patients who are on steroids, we have to monitor them much more closely, right? We're taking temperatures much more often. If the patient has a wound, we're looking at that wound. We're making sure there's no foul odor. We're making sure there's no purulent drainage. And the fourth thing is hyperglycemia. Steroids are full of sugar, so it increases the patient's blood sugar. So yeah, the patient's blood sugar is 189 because they're on steroids. Do we need to address that? Yes, we're going to get that blood sugar down, but that blood sugar isn't so high that their life is at risk, like number one, where that patient is bleeding out and they may die if we don't get to them in time. The client ambulating down the ortho hallway unassisted fell to the floor. Which action should the nurse implement first? 1, complete an adverse occurrence report. 2, notify the clinical manager on the unit. 3, determine whether the client has any injuries. 4, ask why the client was in the hall alone. And the correct answer is 3, determine whether the client has any injuries. So the first thing you want to do is assess your patient. And it's always going to be patient over paperwork. Okay? Paperwork, occurrence report, all of that stuff can wait. You're going to assess your patient and make sure that they are okay. Now, everything else can come afterwards. By the way, let's talk about occurrence report. Let's talk about that. So that's your incident report, guys. Another question they love to ask about, the occurrence report, it never goes in the child. I'm still thinking about peds. It never goes in the patient's medical record. The occurrence or incident report, this is something for the facility to use to know what happened and for them to make policies to prevent it from happening again, okay? So it's an internal, it's something for the facility internally. It does not go in the patient's medical chart. And not only does it not go into the patient's medical chart, you do not even document the mention of an occurrence report. Am I clear? So when it comes to legalities for nursing, you never even document the existence of an occurrence or incident report. That is strictly for the facility. No mention of it. It does not go in the client's medical record, and it should not even be mentioned in the client's medical record. Next question. The unlicensed assistive personnel, that's a CNA, guys, tells the nurse the client with the right above the knee amputation has a large amount of bright red blood on the right leg residual limb. Which action should the nurse implement? 1, assess the client's residual limb dressing. 2, tell the UAP to take the client's pulse and blood pressure. 3, remove the dressing to assess the incision. 4, request the UAP to reinforce the dressing. And the correct answer is 1, assess the client's residual limb dressing. Let me make this clear. Look at me in my eyeball when I tell you this so I can make sure that you guys get this, okay? Whenever anybody comes to tell you something about your patient, you never send them back to do anything for that patient. You go back to the patient. You do not send the CNA, the UAP. I don't care. I don't care if it was another nurse. If they come and tell you something about your patient, you turn around and you go assess your patient. That's why 1 is the answer. So let's look at our other choices. 2, tell the UAP, tell the UAP, yes, UAPs are allowed to take vital signs, but because they came and told you something about your patient, you're going to go assess your patient. You don't go and tell them to do anything for your patient. 3, remove the dressing to assess incision. Here's why you don't do that. Go back to the question. It says that the patient had above the knee amputation. So let me tell you something. That dressing is a compression dressing. Want to know what happens when you remove the compression dressing? That patient's going to bleed out even more. That compression is probably what kept them from bleeding to death until you got there. So you do not remove that dressing, okay? You're going to look at the dressing and you're going to assess the dressing to see the amount of blood that's leaking through and call the doctor if you need to. But that dressing is like, you know, when the patient's bleeding out and you put pressure on the area to stop the bleeding, that's what the dressing's doing for you. So you're not going to remove it and make the problem worse. So that's wrong. And then 4, request the UAP to reinforce the dressing. So we're just going to ignore the problem and we're going to tell the UAP to cover it up by reinforcing? Absolutely not, which is out of their scope of practice anyway. You're going to go and check on that patient. Which action by the unlicensed assistive personnel warrants immediate intervention by the nurse? 1, the UAP tied the confused client to a chair with a sheet. 3, the UAP escorted the client downstairs to smoke a cigarette. C, the UAP bought the client a carbonated beverage from the cafeteria. Or D, the UAP assisted the client to ambulate to the day room area. And the correct answer is 1. The UAP tied the confused client to a chair with a sheet. Guys, want to know what that's called? Battery. You cannot tie a patient down just because they're annoying you. You will lose your license and you will go to jail. That is battery. And look how they try to trick you. Look at 2, escorting them downstairs to smoke a cigarette. We know smoking is bad for you. Smoking is a big no-no, right? So they're trying to tempt you to choose 2. But look at what they're doing. They're just escorting. That means they're walking with the patient. That's all they're doing. So you have to teach the patient, you got to stop smoking. It's not good for you, but you can't force them to stop smoking. And if they're going to walk down the hall, you want the CNA to walk with them so they don't hurt themselves. They don't fall. So there's nothing wrong with 2. There's nothing wrong with 3. They're just buying a beverage. And 4, they're assisting the client to ambulate. They're helping the client walk. The only thing that's wrong is 1, tying a patient down. That is battery. You will lose your license and you will go to jail. The unlicensed assistive personnel on the rehab unit is placing the client with the left above the knee amputation in the prone position. Which action should the nurse implement? 1, tell the UAP to place the client on the back. 2, praise the UAP for positioning the client prone. 3, report this action verbally to the charge nurse. Or 4, explain to the UAP that the client should not be placed on the stomach. And the correct answer is 2. You're going to praise the UAP for positioning the client prone. Why? Because what happens, guys, when a patient has amputation, especially such as above the knee amputation, naturally, without the patient even thinking about it, what that leg, the residual limb, what it wants to do, it wants to just elevate. It wants to elevate. Let me go in the camera so you can see. It wants to do this and go up, right? So what happens, if you allow that to happen, the patient's going to develop contractures and that leg is just going to stay up in the air in that flex position. That's what's going to happen. So several times a day, 4 or 5 times a day, you want to place the patient prone on their stomach to force that residual limb back down so the patient doesn't develop contractures. So the fact that the CNA is placing that patient prone, that's a good thing. You're going to praise them and tell them good job. You want that patient to be prone for 20 to 30 minutes several times a day to avoid that patient developing contractures. I can't believe I'm already at 29 minutes. Guys, I promise part 2 is coming. So we're down to our last question for this video. The charge nurse on the acute care rehab unit is making assignments for the shift. Which client should the charge nurse assign to the most experienced nurse? 1, the client with full thickness burns who's refusing to go to therapy. 2, the client with osteomyelitis who has bone pain and fever. 3, the client with fractured tibia who has deep, unrelenting pain. Or 4, the client with low back pain radiating down the left leg. And I'll give you a moment to think of your answer. The correct answer is 3, by far. By far, this is the patient you are running to. You hear me? This is your priority patient. And they gave you a couple clues, okay? A fractured tibia. So we have a fractured bone, and they have deep, unrelenting pain. What do we know about patients that have fractures and they have not only pain, because when you break a bone, you're going to be in pain, right? But severe pain. You see that word unrelenting? Isn't that same thing as persistent? So what do we know about patients who have broken bone and they have severe pain, and that pain is persistent? That means even with medication, that pain's not going away. What are we suspecting? Compartment syndrome, which is a medical emergency. Okay, that patient has compartment syndrome. They better be rushed immediately to the operating room to get a fasciotomy. Okay, why? Because if that patient has compartment syndrome and that pressure is not relieved, they're going to lose that limb. You want to know who's going to lose their license? You, the nurse. Why? Because before a patient gets to the point where they have to lose their limb from compartment syndrome, there were a lot of signs and symptoms where if you were a good nurse, you were paying attention, you would have caught it, and we would have gotten that patient help in time. All right? That patient has a fracture. The minute they say, you know what? I have a funny feeling in my arm or leg or wherever that fracture is, or I feel numbness, or I feel tingling, immediately you better be calling the doctor. Immediately, by the way, before you call the doctor, you're going to assess your patient, right? You're going to assess them, see if they have pain, see if they have paresthesia, see if they have pallor, right? You're going to be checking all your 6 Ps, and you're going to be making a phone call to the doctor. If by the time that patient's pain is so bad that you figure out what's going on with that patient, that they lose their limb, guess what? You're losing your license. Okay? Fractures, you're going to be checking those 6 Ps. You're going to be making sure the minute that patient says they have a funny feeling, they feel tingling, they feel numbness, you are running to check that patient to make sure that it's not compartment syndrome, because compartment syndrome is a medical emergency. Guys, I hope this video was helpful to you. I promise I'm going to make a part 2. Please, if you know anyone that's struggling with the integumentary system, or even priority and delegation, if you have any classmates that you know these videos would help, please share my videos, guys. Please make sure you press that bell button, the notification, so on Thursdays when I have new videos out, you'll be notified. And most importantly, please support my channel by liking and, more importantly, subscribing to this channel. Thank you so much for spending this time with me, and I'll see you next time.